Good afternoon. I am Dr. Carla Vivar, a third-year resident from St. Luke's Medical Center, Global City, with my interesting case presentation. So going over a brief clinical history of our patient. The patient is a 34-year-old male recently discharged from another institution with a working impression of viral versus toxic encephalitis. The patient presented with episodes of seizures over the past 3 weeks prior to his previous hospital admission. Presently in our institution, the patient is confused with slurred speech and presents with bilateral lower extremity weakness. Other pertinent history for the patient includes 2 instances of head trauma within the last 3 weeks, toxicology panel testing positive for cocaine use, and a known history for alcoholism combined with intake of sleeping pills. So, with this history in mind, they requested for our institution to give our interpretation on the MRI done during his last admission in the other hospital. So, what findings do we expect given this clinical history and pertinent history? So, first off, we could expect that the patient might have a traumatic brain injury since he has history for trauma. Could also expect to see hemorrhagic and/or ischemic infarcts due to his use of cocaine, which I'll explain further later. And we could also see findings of toxic encephalopathy given his history of alcoholism. So I'll just briefly discuss these findings. So for traumatic brain injury, the most common of which would be visual hematomas. So this is axial CT images. These are just examples of uh, visual hematomas in patients. Moving on to hemorrhagic and ischemic infarcts. Now, cocaine abuse increase leads to intracranial hypertension, which can result in spontaneous hemorrhagic infarcts. Patients that also have aneurysms will also have a predisposition to develop hemorrhages. As for the ischemic infarcts, abuse of cocaine may also lead to vasculitis, which in turn can lead to ischemia. So the image on the left is an example of uh, hemorrhage centered on the left putamen, and the image on the right shows a diffusely edematous brain as evidenced by the loss of the gray-white matter differentiation, and these arrows are pointing towards areas of ischemic infarction. Now let's move on to briefly see the MRI images we received from the other institution. So this is just a scroll through of the DII on the left and ADC images on the right from the other institution. So DII and ADC images don't show any areas of restricted diffusion, so we don't have any infarction for this patient. Moving on to T1 and T1 FATSAT with contrast images for this patient, so we can see that the brain has normal architecture, so we don't see any evidence for trauma. Let's move on to T2 and flare images of this patient. Let us scroll through a bit and then focus on the findings. So these are the select flare images, which show hyperintensities involving the periaqueductal gray matter, the mammillary bodies, the dorsomedial thalami bilaterally, and the tectal plate. So given these imaging manifestations alone, what could be our differential diagnosis? So from top of the list, we can consider Wernicke encephalopathy given the distribution of white matter changes on T2 flare. We can also consider some forms of viral encephalitis, which could affect these regions as well. And we can also consider Leigh syndrome if we're just considering the distribution of white matter changes. Uh, for viral encephalitis, here's an example of an MRI of a patient with West Nile virus encephalitis, which you can see that the bilateral thalami have T2 hyperintensities. And for Leigh syndrome is actually a metabolic disease affecting the mitochondria. So in this MRI, we can see that there are T2 flare hyperintensities involving both thalami, the basal ganglia, and the caudate heads. Now, to differentiate between these three pathologies, Wernicke encephalopathy usually has involvement of the mammillary bodies, as we've seen earlier, whereas viral encephalitis and Leigh syndrome typically spare the mammillary bodies. So that leaves us with a working impression of Wernicke encephalopathy. So Wernicke encephalopathy develops secondary to malnutrition, specifically vitamin B1 deficiency, which leads to subsequent loss of membrane integrity, leading to lactic acidosis. It commonly affects the mammillary bodies, hypothalamus, medial thalamic nuclei, pectoral plate, and periaqueductal gray matter. Highlighted are those seen in the patient, and clinically they present classically as confusion, ataxia, and ophthalmoplegia. So management for Wernicke encephalopathy isn't an acute presentation of vitamin B1 deficiency, and this is attributed largely to chronic alcoholism, which the patient presented with. So that's a quick overview of Wernicke encephalopathy. So thanks for spending the time to listen to my presentation.
Thank you so much, Dr. Carlisle. Carlisle, could you go back? How long did the patient present with these signs and symptoms?
Uh, the signs and the signs and symptoms have been presenting over the past 3 weeks prior to his previous hospital admission, and he was admitted to our institution 2 weeks after he was discharged from the first admission, doc. So
3 weeks.
over about a month and a half, doc, in presentation, yeah.
Is he a known alcoholic?
Non-alcoholic, doc.
Known
Chronic
alcoholic.
alcoholism po talaga, doc, siya.
I see, I see. Okay, when given this history, I would just like to give more wisdom to our dear residents whenever you are talking to clinicians, talking to your fellow residents, clinical residents. Okay, think about this, that Wernicke is an acute syndrome. And technically, it is not a radiologic diagnosis. It is a clinical diagnosis. So there should be a chronic history of alcoholism or malnutrition that points to depletion of vitamin B1 or thiamine. So this is an acute MRI finding, but the history should be a chronic one. And when I say it's a chronic one, our body can store thiamine for until 1 to 2 months. And then if there is poor nutrition, if there is severe alcoholism in that certain patient, then it gets depleted. It takes about 1 to 2 months before an acute presentation on MRI can be seen. So please be guided with this timetable when you are asking for the history and for coming up with the diagnosis of Wernicke. Because primarily, the clinician, the neurologist, or whoever is handling the patient should have at the back of his mind entertaining first Wernicke. Of course, we have differentials, and the presentation MRI can have similar differentials with viral encephalitis or any type of encephalitis for this case. So try to think about that, dear residents. Combine the history, combine the presentation. This is more like an acute MRI finding with a chronic background of malnutrition, of vitamin deficiency. Okay, so thank you again, Dr. Carlisle, for this.
Yes, yes, po, doc.
And moving on, we're going to have our last presenter, Dr. Jovenel Cabacan. Okay, Joe. Malabo ang
So,
reception mo, Joe.
I'm Jovinal Kabakan, second year
Joe, Joe, ah, clear ba siya sa inyo? Carlisle, clear ba si Job sa'yo?
Medyo
And
rocky
I'm
here, Doc.
here to present a case of JV, a
Okay.
21-year-old male with 1 month history of intermittent right-sided Hello, Doc.
O yan, clearer ka na.
So again, this is a case with 1 month history of intermittent right-sided chest pain with a pain scale of 8 over 10, non-radiating, with no associated difficulty of breathing, no cough, no fever noted. An X-ray was done in another institution with a reading of suspicious right apical lung opacities. In addition to that, the lungs appear hyperaerated. So this patient was treated as a case of pneumonia and completed unrecalled antibiotic regimen. However, persistence of the right-sided chest pain prompted consult for chest CT in our institution. Pertinent to this patient's case is a past medical history of pneumonia last 2010. So here is an overview of the chest CT of the patient. Take special note of the right lower lobe. Okay. So going back, we see emphysematous changes noted in the right lower lobe, predominantly in the posterior and lateral segments. This area appears to be supplied by an anomalous vessel branching from the thoracic aorta, as seen here. And drainage to this area, drainage is towards the right inferior pulmonary vein. And also within the said affected area is a bronchial-like structure which appears to taper off and without evident communication to the tracheobronchial tree, as seen here. So all these findings are suggestive of pulmonary sequestration. So again, the findings in pulmonary sequestration include a non-functional lung tissue, which may present as a cyst, a mass, a cavitary lesion, a focal atelectasis, bronchiectasis, or emphysematous bleb. There is an anomalous systemic arterial supply, commonly branches from the thoracic or the abdominal aorta, and the affected parenchyma does not communicate to the tracheobronchial tree. A differential for this would be pseudosequestration, wherein the affected lung parenchyma is still supplied by an anomalous systemic arterial supply. However, it maintains a normal tracheobronchial tree as compared to that of pulmonary sequestration. So for pulmonary sequestration, it is further classified into intralobar and extralobar type. Intralobar sequestration is characterized by its presence within the visceral pleura of the functioning lung and commonly with a venous drainage into the pulmonary vein. It typically presents during late childhood, adolescence, or even early adulthood with recurrent pulmonary infections. On the other hand, extralobar sequestration has a separate visceral pleura and the venous drainage typically into the systemic veins, frequently the lower lobe vein, the azygos vein, or the hemiazygos vein. It typically presents in neonatal period with respiratory distress, cyanosis, or infection. As for our patient's case, the sequestered lung segment is within the visceral pleura of the normal functioning lung, and the venous drainage is into the right inferior pulmonary vein, so likely a case of intralobar sequestration. So pulmonary sequestration is a bronchopulmonary foregut malformation which results from an anomalous budding of the embryonic foregut and tracheobronchial tree. There is an estimated 0.1 to 6% incidence among all congenital lung malformations, commonly involving the left lower lobe. About two-thirds of the intralobar sequestration present in the left lower lobe, with male predominance of 4:1 established among extralobar types. It may be associated with congenital pulmonary airway malformation or CPAM, which is characterized with multiple cystic lesions of segmental lung tissue with abnormal bronchial proliferation, and also with scimitar syndrome, characterized with a hypoplastic lung that is drained by an anomalous pulmonary vein into the systemic venous system. So pulmonary lobectomy is the treatment of choice for established pulmonary sequestration, and resection may be done via open thoracotomy or through VATS. The imaging modalities CT and MRI play an essential role in the identification of vascular anatomy prior to the surgical intervention. So here are my references. Thank you for
Thank
listening.
you. Thank you so much, Dr. Job. This is just a reinforcement from the lecture made by Dr. Abby Pernobi and Dr. Ana Pineda last April 14 in our Pediatric Radiology Hour. And this has been emphasized by Dr. Laya as well. So this is a reinforcement as this is seen in an adult patient. It can happen also in adult patients. Oh, are there any more questions from our guests, from our residents, fellows? If there are none, thank you so much again for attending. See you all tomorrow in the next FDR, tomorrow and Friday. And hopefully all of you could attend in our Pediatric Radiology Hour tomorrow night. Our guest consultant will be Dr. Marvin Bautista. Have a good afternoon, everyone. Thank you.
Thank you po, Doc.